Okay,
Yes, we can see your screen. You can start.
Okay, thank you. So, dear colleagues, today I will tell you about antithrombin deficiency in pregnancy, its clinical manifestations, diagnosis, and management. So pregnancy is a physiologically hypercoagulatory condition, which makes the development of venous thrombosis 4 to 5 times increased during pregnancy. The incidence of pregnancy-associated venous thromboembolism is 1 in 1,000 healthy pregnant women. The risk of venous thrombosis is further augmented by any hereditary or acquired thrombophilic disorders. Thrombophilias are well known to cause 50% of venous thromboembolisms in pregnant women. Out of all thrombophilias, antithrombin deficiency presents with the highest risk of thromboembolic events during one's lifetime. In a pregnancy that is complicated with antithrombin deficiency, the risk of thromboembosis is 5 to 10 times higher than in healthy pregnant women. Thrombotic risk in pregnancy ranges from 30 to up to 70% in patients who were not adequately treated and who had previous history of thrombosis. It is well known that different thrombophilias can cause different complications in pregnancy, but data regarding the influence of antithrombin deficiency is still limited. Antithrombin deficiency is the rarest of all hereditary thrombophilias, with prevalence 1 in 2 up to 5,000 persons. Thromboembolism in antithrombin deficiency patients can happen early and can be recurrent, which is quite different from other conditions, and is sometimes life-threatening, which makes this deficiency quite important. It can be divided in type 1 and type 2. So let's say something about antithrombin molecule first. It is a naturally occurring anticoagulant that belongs to a family of serine protease inhibitors. It is one of the most important agents for regulation of hemostasis and prevention of spontaneous intravascular clot formations. It is synthesized in the liver and vascular endothelial cells, and it presents a glucoprotein with a half-life in serum about 2.4 days. Antithrombin has two functional domains. One binding site is for heparin, and the other is for thrombin and factor 10A. Binding of antithrombin to heparin enhances formation of protease inhibitor complex, which mostly inactivates thrombin, but also to some extent all other coagulation factors among 10A, 9A, and 13A are the most important. In the absence of antithrombin, heparin has little effect. So the decrease in 50% of antithrombin activity is sufficient to set the ground for thrombosis in the organism. Antithrombin deficiency has autosomal dominant inheritance, and majority of patients are heterozygous. Homozygous patients are extremely rare, probably because this condition is fatal either in utero or in early neonatal period, although there have been documented homozygote patients, but they had some small genomic defects which caused insignificant activity changes. Antithrombin has high structural flexibility, which makes it vulnerable to mutations. Defects in reactive center carry the highest, and in heparin binding site, the least thrombotic risk. The gene that encodes antithrombin is called SERPINC1, and it is localized on the first chromosome. The first mutation of this gene was found 30 years ago, and nowadays we know for numerous SERPINC1 gene mutations that can cause antithrombin deficiency. Most of these mutations are small point mutations or deletions and insertions, but larger mutations are also reported. Mutations are found throughout the gene, and the most important for clinical manifestations are mutations occurring in the gene coding regions. Based on the mutation type and consequent activity disorder, antithrombin deficiencies can be divided in type 1 and type 2. Type 1 is more common and it encompasses decreased synthesis of the antithrombin molecule. It is caused by short deletions and insertions or single nucleotide polymorphisms in the gene. And these patients with type 1 deficiency have 50% decrease in both plasma antigens and functional activity of antithrombin. As for the type 2 deficiency, it happens due to single base pair substitutions in the reactive site of antithrombin gene. And there can be 3 types of type 2 deficiencies, but all these types lead to qualitative defects of antithrombin, meaning that these patients have normal antithrombin antigen levels, but reduced up to 50% functional activity. Type 2B is the most prevalent, and type 2A is the most thrombogenic deficiency. Deficiency can also be acquired, and there are 3 mechanisms to this. And first is increased excretion. It occurs in renal failure. And then it can be decreased production, as in patients with liver failure, or accelerated consumption, which is a cause of severe trauma or major surgery. But these acquired thrombophilias are quite rare during pregnancy. So as for the clinical presentations and complications in pregnancy, they can be divided as regarding the mother and regarding the fetus. Gestational fetal complications in patients with all thrombophilias, including antithrombin deficiency, originate in vascular lesions in the placenta. Reduced uteroplacental blood flow impairs oxygen delivery to the fetus during pregnancy or during labor, causing different complications. Studies have shown that if antithrombin deficient women receive proper treatment, incidence of pregnancy complications reduces. However, even with proper therapy, 75% of pregnant women with antithrombin deficiency still have venous thromboembolism during pregnancy. Numerous gestational complications are more common in women with antithrombin deficiency than healthy pregnant women, and those are miscarriages, intrauterine growth, fetal restriction, intrauterine fetal death, placental abruption, preeclampsia, HELP syndrome, intrapartum fetal distress. The major clinical manifestation of antithrombin deficiency regarding the mother is thromboembolism. And in these patients, it can occur spontaneously or be recurrent during pregnancy. The risk of thromboembolism recurrency is even 49% in some studies. Recurrent thromboembolias have been described to occur even during one single pregnancy multiple times. The risk of thromboembolism in antithrombin deficient women is tenfold higher if patients have preeclampsia or if it is a multifetal pregnancy. Previous thromboembolism is also a predictor that thromboembolism will occur during pregnancy of antithrombin deficient women. Deep veins of the lower extremities are general localization of thrombosis, but in antithrombin deficient patients, thrombosis may occur on unusual locations. Venous insufficiency and pulmonary embolism or acute fatty liver also are common in pregnancy of women who have antithrombin deficiency. Antithrombin deficiency can also be associated with recurrent miscarriages and infertility. Incidence of miscarriages is twice higher in women who have antithrombin deficiency than general healthy population, while the risk of fetal loss or stillbirth is 5-fold increased. Thromboembolism in antithrombin deficient women who do not receive prophylactic therapy also can occur after delivery, and it occurs in 30 to 50% of women. Pregnancy outcomes in different studies are inconsistent. Adverse effects can occur quite early during pregnancy due to embolism. And if women do not receive adequate prophylaxis or therapy, only 30% of pregnancies end up with a healthy child. However, recently, with the use of appropriate prophylaxis and treatment, majority of both women and children successfully survived the pregnancy. As for the diagnosis, the first step for both asymptomatic and symptomatic women, of course, is detailed personal, medical, and family history. And we're basically paying attention at previous thromboembolism at an early age or the first trimester of pregnancy, which is unusual generally, then to recurrent miscarriages or thromboembolic events in close relatives. The differential diagnosis includes other thrombophilias or other hypercoagulable conditions. And for final diagnosis, of course, complete assessment of coagulation factors is necessary. So the diagnosis is made based on the decrease in antithrombin concentration or functional activity measured by immunologic or functional tests. So if the level of activity is reduced to 60% or less, the condition is confirmed. But some patients can have almost adequate activity of antithrombin, and sometimes incorrect measurements can be obtained if they're measured in acute phase of venous thromboembolism. So in case of clinical suspected antithrombin deficiency and unconvincing laboratory tests, genetic testing should be performed. Monitoring of coagulation factors must be performed throughout the pregnancy because the half-life of serum antithrombin levels changes according to gestational age. In majority of healthy pregnant women, functional activity does not change during pregnancy, but in women who have the antithrombin deficiency, functional activity gradually decreases as pregnancy progresses, and it reaches the lowest percent 4 days after delivery. This activity is even more reduced if patients have preeclampsia or after the 41st gestational week. Management of antithrombin deficiency should be considered according to pregnancy period, therefore. Prophylaxis is essential before and during pregnancy as the risk of thromboembolism increases from first to the third trimester. Nowadays, the first choice during pregnancy for therapy is the use of low molecular weight heparin. Low molecular weight heparin is effective and safe treatment during pregnancy as it does not cross placenta and is not secreted in breast milk. There is a wide range of dosing, and while some recommend low dose, others suggest that pregnant women with antithrombin deficiency should use larger therapeutic doses of low molecular weight heparin. And it can be administered all throughout the pregnancy until delivery without continuous laboratory monitoring because it has few complications. The main disadvantage is the fact that it is a costly therapy. Standard anticoagulation is done with heparin or warfarin, and therapy effects are monitored throughout the pregnancy with functional hemostasis tests, and the dosing is adjusted during the course of pregnancy. However, oral anticoagulants should be ceased prior to pregnancy, and warfarin must be restricted to second and just early third trimester. Although heparin is easy to use during pregnancy, a large amount of heparin alone is necessary to achieve effects, but prolonged heparin therapy, longer than 20 weeks, can have potential adverse effects like thrombocytopenia, bleeding, and decrease in bone mineral density. Antithrombin deficiency is the most common cause of resistance to heparin because heparin needs adequate level of antithrombin to achieve coagulation. During pregnancy, antithrombin concentrate supplementation may also be used as it reduces the risk of both bleeding and thrombosis. Dosing of antithrombin concentrate is based on body weight and baseline antithrombin activity, but so far there are no clear guidelines of dosing and the duration of this therapy after birth. So we're still investigating this. And another thing is that antithrombin concentrate is a blood derivative, which apart from being expensive, can have a risk of viral infection transmission. And therefore, recently, recombinant human antithrombin has been manufactured. It is now clinically available. However, further studies on its dosing, efficacy, and safety are still needed. As for the delivery, conventional heparin should be withdrawn when delivery is planned or started. Actually, after the 37th week of gestation, heparin dosage should be reduced to prevent hemorrhagic complications in delivery. Low molecular weight heparin can generally be continued throughout the labor. And it is also safe to use antithrombin concentrate during delivery. That is why a lot of researchers recommend that antithrombin supplementation is combined with low molecular weight heparin 24 hours prior to planned delivery. After birth, in postpartum period, women may receive heparin. Antithrombin concentrate combined with heparin should be given to all women after delivery to prevent any complications. Also, women can start with oral anticoagulants again, as they're not excreted in breast milk, and low molecular weight heparin can be continued during puerperium because they are quite safe. So, at the end, we should say that antithrombin deficiency is the rarest thrombophilia, but the one with the highest risk of thromboembolism. This risk is increased even more if pregnant women have normal physiological changes that occur in pregnancy, but also have some other coagulable conditions. Therefore, in case of any positive and personal or family history of thrombotic events previous to the pregnancy or recurrent pregnancy losses, among other thrombophilias, we should not avoid testing for antithrombin deficiency. Close monitoring with early and adequate prophylaxis and treatment nowadays can assure positive pregnancy outcome for both mothers and their children. And to achieve these positive effects, it is best for neonatal and maternal outcome to start early with prophylaxis and continue with therapy throughout the pregnancy with low molecular weight heparin and antithrombin concentrate, at least when the pregnancy starts, even better when pregnancy is planned. And this therapy should continue until the end of puerperium. So these are our references along with the paper we have published on this issue, and I thank you for attention.